Questions 1 to 12. You hear a knee specialist talking to a new patient called Jason Riley. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Mr. Riley, you've been referred to me because of a problem with your knee. Is that correct?
Yes, it's my right knee. It's very painful.
Okay. I've got some information here from your GP who's treated you for bursitis. But can you tell me about how this developed and what's happened so far?
Well, about 2 years ago now, my knee, this knee, swelled up and was really big. It didn't hurt, and it just looked really strange. I'd been on a week's golf holiday in Portugal, and the knee was a bit dodgy all the time I was there. Well, when I got home and the wife saw it, she sent me off to the GP straight away, who said that it was what people used to call housemaid's knee. That caused a few laughs at home, I can tell you. Then I remembered that my mum used to get that in her shoulder. It's really called bursitis, isn't it?
Yes.
But he said not to worry, to rest up a bit and wait and see if it went away. And it did in a few weeks.
Right.
So I was okay for a while. Then about a year ago, I got a new job. I used to be a painter and decorator, but I retrained as a carpet fitter. So I'm on my knees quite a bit. Goes with the job. And after a while, this must be about 6 months ago, the knee swelled up again. It looked really red this time, and I had a sort of dull pain as well that got worse.
Okay.
Also, I felt slightly shivery and feverish. The GP said I probably had an infection and gave me some antibiotics for 10 days or so. That seemed to do the trick, and I felt much better, but the knee was still a bit swollen, and it ached sometimes.
Did you try painkillers?
Oh yeah, after a bit, the doctor suggested ibuprofen, but that always seems to give me a tummy upset, so I stuck to paracetamol. I'm still using them on and off. At work, they put me on to doing things that didn't need a lot of kneeling when I first went back, but only temporarily. And I put ice packs on my knee to bring down the swelling as often as I could, every few hours. I tried to take breaks too. Oh, and my GP suggested some exercises to protect the knee, lying down on my back and raising the leg.
Yes.
Which seems to reduce the aching. In bed, I made sure I slept with a pillow under it to keep it a bit higher up too.
Was your knee still swollen?
Yeah, it was. So then the doctor drained off some of the fluid by sticking in a needle. I remember he said he got 20 millilitres out.
Right.
After that, he suggested that I try some supports in my shoes. I couldn't really see the point of that, but apparently it's to do with your arches, which I guess does affect your knees.
Yes.
Also, he told me to make sure that I have plenty of padding on my knees when I'm at work, and I've been doing that.
Good.
He told me that I should think about losing a good few kilos as well, but I like my food, as you can see, and I haven't made any progress with that so far. But things weren't getting better, so then he started giving me cortisone injections. I've had 3 of those so far.
And what effect did they have?
They really helped. Much less swelling, and the pain's better too. But that's the problem. He now says that with those sorts of drugs, you can't have more than 3 of them in the same knee in a year. I'm up to the limit, and it keeps coming back, so really I'm hoping you'll be able to come up with something better.
Okay. Well, let's have a look, shall we?
In this part of the test, you will hear Dr. Jane Hope interviewing Henry Bunyan, a patient with a recent problem.
Come on in, Henry. How are you this morning?
Not too bad, thanks, Doctor, and yourself?
Oh, well, busy as usual.
Yeah, I can see that. There are a lot of customers in the waiting room.
Yeah.
There was a nice spot of rain we got last night.
Yes, it certainly saved watering the garden, and that was a bonus. So, Henry, have you come for your blood test results?
Yeah, that's right. Give us the news, Doctor.
Well, it's not bad news, but your total cholesterol was 6.6, your triglycerides 1.6, and your HDL was 1.54, and the LDL was 4.65.
So what does that all mean, Doctor?
Well, you remember we did the same test a year ago?
Yeah.
So what these current results show now is that compared with last year's results, there has been a sharp rise in your LDL level.
Yes, well, what's brought this about?
Well, as we discussed last year, cholesterol is carried in the blood by different types of protein carriers called lipoproteins.
Yeah, I remember that.
Well, the two which carry the most cholesterol are the low-density lipoproteins, LDLs, which we believe promote atherosclerosis or thickening of the arteries, while high-density lipoproteins, HDLs, tend to prevent this. In your case, unfortunately, your LDL has increased, and there are a number of factors that may have contributed to the rise in your LDL. For instance, a higher fat content in your diet,
Right.
increase in stress,
Mm-hmm.
maybe you're not exercising as much as you were.
I guess I'm not.
That's right. Have you noticed any discomfort or had any general health issues that have caused you concern lately?
No, not really.
Okay, now Henry, I know your family history and that your dad died of a stroke at 60. I just want to ask you a few questions about what you're doing now.
Sure.
What about your current diet? Are you eating much fatty food?
Yeah, I guess so. I mean, I do enjoy McDonald's at lunchtime and eat quite a bit of meat. I'm not really a big fan of vegetables.
Yeah. Have you noticed any change in weight? Do you think you've gained a little?
Well, since I last saw you, I've probably put on about 5 kilograms.
Yeah, well, that's quite substantial. What about exercise? Do you still manage to do that regularly? I remember last time you told me that you were taking your dog for a run once or twice a week and that you swim regularly.
Well, actually, in the last year I've been pretty busy at work and I've had a lot of family commitments lately, so I probably exercise a bit less.
And are you still smoking?
Yes, I am. I've tried to cut down though. I'm probably smoking 5 or 10 cigarettes a day.
Okay. And how about alcohol? How many alcoholic drinks do you have in a week?
Well, in a week, I probably have 2 or 3 a day, so I don't know if you multiply that, I guess it adds up to quite a few, 16 or more maybe.
And would you say that you drink more at the weekend?
Yeah, a little bit more on the weekend. We have a glass of wine as well at night sometimes.
Right. Okay.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Anne Greenall is undergoing an asthma screening, interacting with a respiratory therapist despite the fact she can't hear a thing. She doesn't have to. A translator is bridging the gap.
I'm able to communicate effectively with hearing people.
The Americans with Disabilities Act requires hospitals to provide effective communication for the hearing impaired in all healthcare settings. It doesn't mandate a method, but computers can't compete.
Of course, there's a lot of technologies out there, but you cannot eliminate the face-to-face.
So you haven't had to use that?
No, I haven't used it.
It sets the patient at ease, and it sets the patient care provider at ease, because Lee Memorial Patient Care Team really wants to make sure that the patient leaves fully understanding their care.
Communication being a two-way street, the translating works both ways, giving health information to the patient, but also getting feedback in return. In that way, doctors and health professionals can hear the patient's questions and concerns.
We consider all the people that we work with are deaf consumers. So not only when we come into a situation, hearing people are also people that we're interpreting for.
Anne is all smiles at the end of her appointment. A potentially stressful situation is translated to a pleasant experience.
Let me help you get these slippers off. You did a great job on that walk.
You sure did, Ms. Adams. How are you feeling?
Well, I'm kind of glad it's over. It will get easier, won't it?
Oh, it will, hon. It will.
That's what we're working towards. So if you both look at the board here, it's spelled out. Mr. Adams, I'm really glad that you're able to be here when we're walking with your wife, because I think it's going to give you a better sense of what to expect once you're home and how her recovery is progressing.
Oh, it certainly will.
Now, we gave her the pain medication an hour before she walked so that she would feel comfortable. Then, as you saw, when we got her out of bed, we had her sit on the edge of the bed to make sure she wasn't dizzy from the medications. Then we had her stand for a minute to make sure she was okay before she started walking. That's going to be important to continue once you're at home.
Uh-huh.
And we also talked about how it's important for Ms. Adams to get all of her medications on time at home. She's on a blood thinner to prevent blood clots, and walking also keeps her blood circulating and will prevent clotting as well.
Yeah, I really like that little calendar you showed me that has all the times charted out. But, you know, I'm not sure either one of us is clear on the dose of each medicine.
He's right about that.
I'm really glad you told me this. This is exactly the kind of information I need to know. I'll go over the doses now, and we'll review them again when Ms. Adams is discharged. Plus, I have some printed materials to give you when you go home as well.
Thanks. That'll be really helpful.
Today, we're trying to understand and feel confident and competent when providing care for young patients who exhibit anger or aggression. Aggressive behaviors bring the potential for harm. Concern about this is legitimate. It's perfectly okay to be on guard and careful when someone poses a risk. The key is to push through our apprehension, to manage the situation, as well as to provide good care. This kind of behavior in children is sometimes surprising, and many times the intensity and the child's capacity for strength is alarming. In this module, we want to look at two elements of managing these behaviors. First is understanding the underlying reasons why the child may be behaving this way.
Hello, how may I help you?
I would like to make an appointment with Dr. Smith, please.
What would you like to see him for?
I need my annual physical and also have a shoulder problem. It is aching.
Dr. Smith has openings next week. Are you free on Monday or Tuesday?
I am free on Tuesday afternoon.
We will schedule you for next week, Tuesday at 3 p.m. Hi, doctor. I came today because I need a flu shot and to get a checkup.
Okay. Have you had a flu shot in the past year?
No, not in the last few years. My knee hurts as well. I have been running a lot more and think it is injured.
When did the pain start, and does it still hurt now?
About 2 weeks ago, and yes, it still hurts.
I suggest you ice it, and I will prescribe you some pain medication.
Thank you, doctor.
Hello, I'm here to visit my sister.
What is your sister's name?
Her name is Antoinette Simmons. She is going to have a baby.
Oh, congratulations. Yes, I see here Ms. Simmons is in the maternity ward. Do you need directions?
Yes, please.
She is in the East Wing. Take this elevator to the 3rd floor and walk down the hall, then make a right turn. She is in room 304.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 through 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear a medical podcast on the guidelines for coping with Prader-Willi syndrome. You have 90 seconds to read questions 31 to 36. Hello, Mrs. Araceli. I am Dr. Gonzalez.
Hello, doctor. I would like to tell you something about myself.
Yes, please.
I have been married for 55 years and we have 3 children. The second child, who was born in 1964, had every kind of physical problem and was in the hospital for 10 months. However, we did not have a diagnosis until she was 4.5.
What does the diagnosis indicate?
Prader-Willi syndrome.
Prader-Willi syndrome?
Yes, it had a severe impact on my child in very complicated ways, mainly the damage of the 2 primary areas of the brain, the deletion of chromosomes 15 and hyperplasia. She is always feeling and thinking about food the whole time, akin to the feeling of starvation, and she never has the feeling of satiety. So this affects her daily life in an extreme way, and her tolerance level and the temper control, which is affected greatly.
Over the years, you would have experienced the communication skills of your doctor a lot. What is your impression in general?
We've been very fortunate for not having any bitter experience over the diagnosis. However, later on we have realized that he had suggested blood tests for her that were not actually required. That was the only bitter experience we had.
Actually, Prader-Willi syndrome is a complicated genetic condition that severely impacts several parts of the body. In infancy, this condition is identified by weak muscle tone called hypotonia, difficulties in feeding, poor growth, and delayed cognitive development. The patients develop an insatiable appetite right from the childhood, resulting in chronic overeating called hyperphagia and obesity. Some patients with Prader-Willi syndrome, especially those with obesity, also develop the most common form of diabetes called type 2 diabetes. The patients will typically have mild to moderate intellectual impairment and cognitive disabilities. Behavioral problems are very common, such as stubbornness, temper outbursts, and compulsive behavior. Sleep abnormalities can also be seen in the patients. Distinctive facial features such as almond-shaped eyes, triangular mouth, and a narrow forehead. Short in height, small feet and hands. Patients even have light-colored hair and unusually fair skin. Male as well as female patients will have underdeveloped genitals, delayed or incomplete puberty, and infertility is also common.
So is there any chance of curing Prader-Willi syndrome, doctor?
Yeah, but it's a lengthy process. Parents can enroll infants with Prader-Willi syndrome in early intervention programs. However, even if the diagnosis is delayed, treatments are available at any age. Therefore, for the patients with Prader-Willi syndrome, the types of treatment depend on the patient's symptoms. You can adopt any of the following steps that are suitable for the patient. Can use nipples or tubes for the patients with feeding difficulties. Special nipples or tubes have to be used for several months to feed the child with feeding difficulties, to make sure that the infant is fed completely and it has proper growth. The healthcare provider will monitor weight, height, and body mass index periodically to ensure proper growth. By supervising the daily food intake, the parents could prevent the overeating behavior that starts from 2 to 4 years of age. This will minimize food hoarding and prevent rapid weight gain and obesity. Growth hormone therapy has to be performed to increase lean body mass, mobility, and height. To reduce fat mass and improve movement and flexibility from infancy through adulthood, if the growth hormone therapy is given early in life, it may reduce or prevent behavioral difficulties. In addition, this can help improve speech, cognitive ability, abstract reasoning, and often promote information to be processed very quickly. It also improves sleep quality and resting energy expenditure. Growth hormone therapy is usually started during infancy or immediately after the diagnosis, and often continues during adulthood at 20% to 25% of the recommended dose for the patient. Many patients have trouble getting their eyes focused together. Such patients should be referred to a pediatric ophthalmologist. If necessary, an orthopedist will evaluate and treat the curvature of the spine called scoliosis. Sleep disorders are very common in Prader-Willi syndrome patients. Treating a sleep disorder in an early stage would help improve the quality of sleep. Muscle weakness is a serious issue among the patients with PWS. For children younger than 3 years of age, a physical therapy is essential to increase muscular strength to achieve developmental milestones. Generally, the patients have difficulty in controlling their emotions. Therefore, a behavioral therapy could help to control anger, obsessive-compulsive behavior, and stubbornness, including an obsession with food. Medications, such as serotonin reuptake inhibitors, may reduce obsessive-compulsive behavior and also help manage psychosis.
Thank you very much, Doctor. That's been really useful. Thank you.
Thank you, Mrs. Araceli.
Now look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of hernias. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain to us about different types of hernias?
Well, inguinal hernias are located in the lower abdomen just above the leg crease, adjacent or near the pubic region. At times, they can also occur on both sides of the pubic area, which is called bilateral inguinal hernias. Inguinal hernias, along with femoral hernias, make up the two types of groin hernias and can cause pain that extends into the upper thigh or scrotum. Inguinal hernias can be categorized as direct or indirect. An indirect inguinal hernia occurs due to natural weakness in the internal inguinal ring, while a direct inguinal hernia caused due to the weakness in the floor of the inguinal canal and is more likely to develop in men above 40. The floor of the inguinal canal is located just below the internal inguinal ring. When inguinal hernias are repaired using the tension repair technique, recurrence rates may be more than 15%. However, other techniques used for hernia repair, such as tension-free and laparoscopic tension-free, have much lower recurrence rates of just 1%. A sportsman's hernia is a condition of chronic exercise-related suprainguinal groin pain. Generally, it involves a direct inguinal hernia. Femoral hernias, along with inguinal hernias, are groin hernias, which are very common in women but can occur in men as well. A weakness in the lower groin makes the intestinal sac to drop into the femoral canal, a space near the femoral vein that carries blood from the leg. These hernias are highly prone to develop incarceration or strangulation as an early complication. Incisional hernias appears in the abdomen at the site of a previous surgery that can appear weeks, months, or even years after a surgery and can vary in size from small to very large and complex. Umbilical hernias appear near the belly button or navel due to a common weakness from the blood vessels of the umbilical cord. This may occur in infants at or just after birth and may resolve by 3 or 4 years of age. However, in adults, umbilical hernias will not resolve and may progressively worsen over time. Epigastric hernias are more common in men than women. They occur due to a weakness or opening in the muscles or tendons of the upper abdominal wall on a line between the breastbone and the navel or umbilicus. Spigelian hernias, a protrusion of intestine or an empty sac through a weakness between the muscle fibers of the abdominal wall, often on the right-hand side of the abdomen. It becomes impossible to detect because often there is no obvious swelling or lump. It develops between the muscles of the abdominal wall rather than protruding through layers of fat. It often develops in later life of men and women when the abdominal muscles become weaker. Hiatal hernias are slightly different from other types of hernias because they are a weakness or opening in the diaphragm that separates the chest cavity from the abdominal cavity. These hernias cause reflux of acid from the stomach into the esophagus, resulting in heartburn, pain, and erosion of the esophagus.